morning. Welcome to the Los Angeles World Affairs Council and Town Hall. I'm Kim Maclay, President and CEO, and it's my great pleasure to welcome you to today's program. Please stay tuned to the end of today's program for a brief update on all of our upcoming programs, which are now beginning to include in-person programs as well. For those of you who would like to ask questions of our panelist and moderator, there's a control panel on the right-hand side of your screen where you can type in your questions. Jessica DeGanzik, our Vice President of Events, will be managing your questions during the Q&A portion of today's program, which will start in about 25 to 30 minutes. It is now my great pleasure to introduce today's program. Reimagining Healthcare in Our Post-Pandemic World. We're very pleased to have Leonard Schaeffer, founding chairman and CEO of WellPoint, the nation's largest health benefits company. He is also the Judge Robert Maclay Widney Chair and professor at the University of Southern California. Our moderator today will be our very own board member, Robert Abernethy, who in addition to being a trustee at the Brookings Institute, is also founder and president of the Tech Center. Bob, it's time for me to bring you on and introduce Leonard and get this great program going.
Thank you, Kim. I wanted to welcome all of my fellow members of Town Hall and the World Affairs Council to this meeting today. I'm delighted to be able to be with you during the upcoming hour. You know, we go back a few years in Los Angeles. Town Hall was founded in 1937 and the World Affairs Council in 1953. We recently merged together. I joined both organizations in 1969. That dates me a little bit more than I like to be dated, but that's what's so. We are coming out of COVID very healthy and very strong. Many thanks to our leadership that Kim Maclay has provided us as our president and chief executive officer. She and her colleagues have a string of very interesting programs for all of us to participate in as we move through the summer and into the fall. I would like to say hello to my longtime good friend, Leonard Schaeffer. We have served well together in both Brookings and Fran in Santa Monica for many years. He got his original university education at Princeton. But before he came to Princeton, he came from a family that had inculcated health and care of people, I think, from the very beginning. His father was a pharmacist and his mother was a social worker. So I think they set him on a trajectory which you will see as we move through this program has enabled him to accomplish amazing things in helping large numbers of people in healthcare in the United States. I could spend the entire program letting you know about the various awards he's gotten, the jobs he's held, but I'll just briefly touch on a couple of them. He has had a lot of service with the Department of Health, Education, and Welfare and Human Services, and he has a distinguished public service award from those departments. He was Assistant Secretary for Management and Budget of Healthcare, and here is a job that I have a hard time getting my mind around. He was administrator of the Medicare and Medicaid programs. I just think about trying to do that job, and it just is mind-boggling that anybody would be able to start doing it, much less have the success that Leonard has had. He is, as Kim said, been president and CEO of Blue Cross of California. He was recruited into that job in 1986 at a time that that organization, and I was one of its members, had a $2 billion revenue, but it had an annual loss of $150 million a year. Just boggles my mind to think about losing $150 million year after year. I don't know how to think about that point, but anyway, he turned that organization around, established WellPoint, which I now think is called Anthem. I'm still a member of that organization. In 2003, they had $212 billion of revenue with an annual profit of $935 million. If you think about it, those are just crazy numbers. They're large, and you know, today Anthem has, along with myself, another 41 million members and a $122 billion revenue. Anyway, good friend Leonard, welcome. Delighted to have you here with us this morning. It's your show.
Well, Bob, thank you very much. I appreciate your kind introduction and want to emphasize something that you mentioned, which is that I'm not a physician or a scientist. However, I've worked as a regulator, a payer, and as a manager of health systems. And as a result, I'm very interested in how all of those functions coordinate, and we end up with our American healthcare system. The good news is that that system is filled with good people and very capable clinicians. However, it fails to do all that's necessary to keep Americans healthy. And by virtue of its size and its cost, it creates problems for other parts of our economy. So what I'd like to do, and I only have 5 slides, no one should fall asleep, is to give you a little background on the size and the complexity and the impact of the healthcare, our American healthcare system on the rest of the country. I think you can click one more time, and here you go. If you look around the world, you find that most healthcare systems want to accomplish 3 goals. First, high quality care. Second, to do it with an affordable cost. And third, make that care accessible for all. Very, very hard to do. Most countries haven't been able to do it. We here in America, we're always have been very proud of our system. And if you click on the next slide, please, we used to believe some things. We thought that we were the highest quality healthcare system in the world, and that meant it would be high cost, because we left, unlike most other developed countries, we left healthcare in the market economy. So if you want to buy a Rolls Royce, you've got to pay a lot of money for that. If you want great care, you have to pay a lot of money, which resulted in limiting access to care. Now, we believe those things, but they were never true. The reality is the United States has a healthcare system that provides very uneven quality. It is the highest cost by far. And by virtue of that high cost, the fact that wages have not increased anywhere near as quickly as costs, we have actually limited access to the American healthcare system. So your financial status and your physical location determine whether you get the kind of care that is available, which is high quality care, or you get less than high quality care. I want to take a minute and talk about costs because that's how the healthcare system connects to the rest of the world. So if you would go to the next slide. And I have to mention that this is a slide put out by CMS, the Centers for Medicare and Medicaid Services, and it doesn't include the impact of COVID. But ironically, COVID last year reduced healthcare spending. But this year and going forward, by virtue of delayed diagnosis and delayed treatment during the COVID period, healthcare will probably grow faster than what this chart shows. And what it shows is that according to CMS, between 2019 and 2028, healthcare spending will grow by 5.4% a year, which is, and this is the important point, 1 percentage point faster than the gross national product. So what that means is healthcare is taking a bigger and bigger portion of our total productivity as a country. And that's as a result of two things that are happening. One, prices of medical goods and services continue to go up. And two, the American population is aging, and more people are becoming eligible for Medicare. Some 10,000 people a day join the Medicare ranks. It's very important to understand how healthcare, and particularly Medicare and Medicaid costs, impact federal spending. So let's go to the next chart real quick. And I would ask you to take, I'm a big believer in bar charts. If you take a close look at it, what you see is this is federal spending as a percentage of the gross domestic product. And the orange area is everything except healthcare, interest, and Social Security. And the irony, of course, is that is going down as a percent of GDP as our productivity grows. Social Security goes up because people are getting older, but it goes up from 4.2% to 6.3% over this 60-year period. Not so bad. Net interest on the debt has been low because of low interest rates, but what's being projected here is a big jump, both in the amount of interest, the amount of debt we have, and what we're going to have to pay as a percentage. But what's important to note is the biggest increase and the biggest single piece when we get to 2051 is healthcare. From 2.3% of the gross domestic product to 9.4%. And what's the impact of that kind of growth? We can go to the next slide. The first thing it does is it makes healthcare increasingly unaffordable for individuals. In 2020, healthcare premiums went up by about 4%. And for the average family that gets insurance through an employer, the cost for family insurance each year was $21,342. That's pretty expensive. And if you're not employed, typically beyond what you can afford. Also, this dramatic growth, today, healthcare is 18% of the GDP. It crowds out all kinds of other things that we want to do, and it crowds them out at an increasing rate because it's growing faster than the economy. And then, as I mentioned on the previous slide, that dramatic growth increases both the federal debt and interest costs. So long-term, high and rising healthcare costs are a significant threat to the economy. Alice Rivlin had this right. What she said is long-run fiscal policy, which is what economists like to talk about, is really health policy. Healthcare policy, so we want to focus on what the government and what economists are telling us is going on and what should be done to maintain the prosperity of our country. The issue, however, is that when we look at healthcare and we look at decisions that are being made by policymakers, what we find is that healthcare policy and legislation is never just about healthcare. Let's go to the final slide. What drives decisions around healthcare, which leads to some of the problems that I mentioned on the previous slide, is first, how much does it cost? Can we afford it? Second, disagreements about what the role of government should be in something as important to all of us as our healthcare. And finally, social values. It's almost impossible to have a discussion about healthcare without getting into things like abortion, which is an important issue, but really shouldn't shape, or these social values should not necessarily shape our healthcare policies. However, healthcare costs drive our accumulated debt. As I hopefully demonstrated in earlier slides, that threatens the economy and national security. So what's going to happen? Well, if costs are not contained, you're going to see deficit hawks, elected officials who do not want the debt to continue to grow, and national security experts who don't want all the money to go into healthcare. They need money for defense and for other parts of our security. They'll join together to try to reduce the federal budget and the federal debt by reducing healthcare costs. And the easiest way to do that, and usually the only way to do it quickly, is what are called a sequester or across-the-board cuts. So what you do is you cut everything by 5%, which in healthcare is absolutely the worst way to do it, because what you've got is all the problems we started with remain. You just have less money to provide care for Americans. One of the things that could eventuate as a result of all of this is, and I'm using this term very loosely, but it would be an American version of a single payer system. We'd have the government regulating all of the healthcare issues as they do with Medicare and Medicaid, but it could go broader. But the administration and the care delivery would go through non-government entities, because historically, at least, Americans have wanted a market-based system. Well, on this less than optimistic note, Bob, I think you had some questions, and we ought to go to them.
Well, I do, Leonard. Thank you. You know, you seem very concerned about rising healthcare costs. What's really driving them?
Well, the thing to understand about healthcare is the way it is paid for, the way it's reimbursed. Fee-for-service reimbursement is the biggest structural factor that drives healthcare costs. And fee-for-service reimbursement occurs when doctors and other healthcare professionals receive a fee for each service that they deliver. And this is because we've left healthcare in the market economy. That's how you pay doctors, that's how you pay lawyers, that's how you pay professionals. However, fee-for-service rewards medical providers for volume of service provided, regardless of the outcome. It's a system of payment that creates incentives to provide more, frequently unnecessary, duplicative, and sometimes even harmful care. This supplier-induced demand does not put the patient's interest first. So we've got to find a way to replace fee-for-service if we want to get to patient-centered care. A value-based payment system with reimbursement for health outcomes would ensure that new drugs and new procedures are delivered appropriately. Currently, however, the most important trend is hospital and health system consolidation, which, according to good research, has given providers growing market power and has actually increased prices. Anyhow, what we got to do is move from fee-for-service medicine.
What's the role that prescription drugs play in driving spending?
Well, prescription drugs cost for about 10% of total healthcare spending, which doesn't sound like much. But what's interesting about drug costs is they go up as total costs go up. So drugs have been 10% of healthcare for quite a long time. The increase in drug costs is both generic and brand name drugs. And the reason it becomes a big issue is that drug prices become a burden for individual American consumers because they frequently have deductibles and co-payments. And you know, your insurance allegedly takes care of all the big costs, but you can go to your local drugstore and have to fork over serious amounts of money because the costs are going up or the prices are going up, and you have this this problem of deductibles and co-insurance. There's also a big challenge around drug prices as America ages. Modern medicine has done some miracles and has converted many diseases that were once terminal into chronic conditions. But if you have one of those conditions, you have to keep on taking drugs, well, continually to maintain your chronic as opposed to terminal health status. Well, that's very good for people to live longer, but it's very expensive. And that's one of the reasons that Americans are very concerned about healthcare costs.
What can public or private players do to control these costs?
Well, many health plans that serve both the government and the private or the public sector have done two things that we hope would be helpful. The first was increased patient cost sharing. And the theory was that people are price sensitive in the rest of the economy, they will be price sensitive in healthcare. It doesn't work. You know, as a consumer in the American economy, you decide what it is you want to buy and you do price shopping. In healthcare, you don't decide, your doctor decides, and it's very hard to discover what the prices are for what you think you need until you've already gotten it. The other thing is narrow provider networks where insurance plans guide people to lower cost providers. That has worked a little bit better, you know, PPOs, but when it was really put into place with HMOs, it was not taken very kindly by either employers or employees. Well, the real solution is for payers, both government and private payers, to transition to value-based payment methods that reward value or outcome, not volume. And I'm hopeful that we can see that begin to happen, because under value-based care agreements, providers assume risk for helping patients improve their health and for reducing the impact of disease. We have to go beyond sickness and injury care. We have to have a healthcare system that focuses on prevention and maintaining the health status of all Americans.
Well, how do you think that American healthcare compares to other developed countries?
Well, there are lots of ways to compare, and unfortunately, we don't do very well on any of them. The United States spends significantly more on healthcare as a share of the economy than any other country. But our population outcomes, our health outcomes, are worse. And I'm going to read this because I want to make sure I say it right. The U.S. has the lowest life expectancy, the highest infant mortality rate, and the highest chronic disease burden. That means arthritis, asthma, lung disease, diabetes, heart disease, and hypertension among all developed countries. I mean, that's pretty sad. The U.S. also has an obesity rate that is 2 times higher than the OECD average. Compared to our peer nations, developed nations, the U.S. has among the highest number of hospitalizations from preventable causes like diabetes and hypertension, and the highest rate of avoidable death from diabetes, hypertension, and cancers, certain cancers. Americans also uniquely use very expensive technologies. We use more MRIs, more specialized procedures, more hip replacements, much more often than our peer countries. Now, as I said earlier, we do have very talented people, and so we do outperform in certain areas, such as preventive measures, including breast cancer screening, and flu vaccinations. But broadly speaking, we fall behind most other developed countries.
Is there anything that we could learn about healthcare from any of these other developed countries, Leonard?
Well, we can learn a lot, and I could take up all the time we have to talk about some of the things that have been learned. But there's a bigger issue that I think is a major health policy issues, and I hope the people that are in the audience today will take this away. When you look at these other countries that have so much better outcomes than we do, what you find is they spend much less on healthcare, but much more on social services that address what are called the social determinants of health. There's a lot of research that shows that social determinants of health, including housing, nutrition, and transportation, can improve health outcomes and reduce healthcare use, particularly for vulnerable populations. And this is the key thing. Remember, we left healthcare and everything else in the market economy. So if you can't afford to take a taxi, to see the doctor, or if you can't afford nutritious meals, you don't get them. And those are, you and your children don't get them, and those are what are called social determinants of health. Now, U.S. healthcare organizations haven't invested in providing the social supports for several good reasons. The first is insurers and the government don't pay healthcare providers for providing social services. And second, if you think about it, given the way we're organized, doctors, hospitals, and clinics can't really organize services that are provided outside of their medical walls. Now, we'll talk later about some health systems that are trying to do that, but it's an added cost and it's an added set of skills, and not too many of them are good at it.
We hear these days an awful lot about the words artificial intelligence. Can this arena of artificial intelligence change healthcare? Is there any possibility that it could help lower the cost?
Well, I think on the first part of your question, artificial intelligence, excuse me, will have a big impact on healthcare, both diagnosis and treatment. And the pandemic, I think, has accelerated the use of artificial intelligence. And from an economic point of view, last year, healthcare, our AI startups received $4 billion in funding. So it's coming. I mean, we're already seeing robot-assisted surgery. We're seeing, and I'm a big believer in this, artificial intelligence-assisted analysis of imaging. In other words, it turns out in many cases that an AI system can read an X-ray better than a human being can. The big opportunity, though, is combining artificial intelligence and telemedicine. And that'll happen when we begin to have remote monitoring devices, so that you don't have to go in to see the doctor. You can talk to the doctor on the, as we are now on television or on Zoom. And with remote monitoring, he or she can know how you're doing and decide whether you need to come in or whether there are things you can do at home. And I'm very optimistic about that. The problem is that there's so many applications of AI that it's not clear that it will lower costs. I'm very hopeful it'll improve quality, that it will improve, quality, but I don't know that it'll lower costs. The other issue, and we're seeing this across the board with artificial intelligence, is there are frequently hidden biases in the algorithms that run AI, and they could lead to either inappropriate treatment or in some ways limit access. So we got to be careful. Long run, it ought to be very helpful. Not clear that it will save money, but we've got some work to do.
Costs seem like an intractable problem. COVID-19 may make matters worse. A significant part of our population refuses to be vaccinated. I know the Schaeffer Center at USC, which you founded, has researched the challenge. What were that center's conclusions about these questions?
It's a very interesting question, but your question also points out the point I was making earlier. The answer is not based on healthcare. The answer is based on sociology and psychology, which are important, critically important to deal with this healthcare problem. Well, the Schaeffer Center has been hosting forums and conducting polling research on what's called, vaccine hesitancy. They learned a few things that I think will be helpful in terms of getting more people vaccinated. The first thing that stands out, as they identified skeptics and have been polling consistently for quite some time, is that these skeptics are not just one group of the population. They differ in terms of age, education, ethnicity, and geography. It's a whole bunch of different people for a whole bunch of different reasons. Okay. While this diversity increases the challenge, they've also come across some behavioral science insights that I think work across most of the groups. And here's a very interesting factoid based on their research, that based on their surveys, about half of people who say they are hesitant eventually change their minds. But you got to keep working to get that mind set changed. Second, they found that clinician-led encouragement is critical, but it's got to involve approaches that are tailored. The message has to be tailored to the specific population in terms, age, gender, ethnicity, etc. And finally, and this sounds so obvious, we've learned that people are much more likely to get vaccinated if it's easy to get that done. For example, providers or pharmacies can offer an appointment which can easily be rescheduled. Then people will, if they miss the first one, they'll get the second one. That's fine. Also, you want to provide the vaccines in pharmacies that are in your neighborhood. Even better is other locations that are close to people's homes or in churches or schools or other places that they visit regularly. Some cities are doing I think the optimal thing, when they're literally dispatching qualified people to give vaccines in individuals' homes, literally knocking on the door, explaining that they can get a vaccine and doing it right there, which is the best way to get it done. It's very sad that after finally getting the vaccination process going, things have slowed down. But we can't let that continue. We've got to get everybody vaccinated.
We've heard a lot about herd immunity. What is it, and what happens if we never reach it?
Well, a lot of discussion, but everything we know about herd immunity and immunity period is based on other viruses and other diseases. And herd immunity is not the same as the total eradication of a disease. This goal of 70% of the population would help slow the spread of COVID-19 to a level so it would become something like seasonal flu or measles and could be managed by focusing on local outbreaks. Unfortunately, it's not clear that we'll even achieve that 70% goal. So we will continue, I think, to see surges in areas of low vaccination rates. And there's a term of art that the CDC coined that I thought was interesting. They're saying that we now have a pandemic of the unvaccinated. In addition, we can expect more mutations like this, but similar to the Delta variant. The good news there is, although there are breakthrough COVID cases among the vaccinated, people who are first vaccinated and then have a breakthrough usually get a much less severe experience and don't require hospitalization, and very, very rarely does it lead to death. The thing that is troublesome is we don't know what the full range of long-term health impact is on people who have contracted COVID. And so there could be long-term implications we're not aware of, and probably long-term costs that we'll have to deal with.
How do you think those costs will be impacted, and what do you think those long-term effects on a health care system will be?
Well, yeah, the irony of COVID is that initially it reduced healthcare spending significantly because people stopped going to see their doctors and they stopped having elective surgery. The problem is that the pent-up demand is now, coming into the healthcare system, and more importantly, what is going to be the impact of people delaying the diagnostic procedures that they should have had and not dealing with their chronic conditions appropriately? In other words, are we going to end up with people turning out to be sicker and needing more care than they should have or would have if we had diagnosed and treat them earlier? So it'll probably lead to higher costs and more illness until we can get to the point where it is basically like the seasonal flu.
You mentioned telehealth care. What do you think the long-term impact of that will be as we come out of this COVID-19 pandemic and go into a more normal state of affairs?
Well, I think it's a little like the impact that doing work from home had on a lot of people doing their own work. it's pretty easy just to turn on the computer, and I don't have to excuse me, drive through rush hour. My commute goes away. And so I think a lot of Americans are going to like the ability to just turn on the computer and talk to the doctor. A recent McKinsey study found that telehealth use seems to have stabilized at a rate that is almost 38 times higher than it was based on pre-COVID levels. So I think both patients and hopefully doctors will find it positive. The issue, though, is, again, we have to get back to reimbursement. How are physicians and other clinicians going to be reimbursed? Plus, are we going to also develop these remote monitoring devices that allow people to interact with their doctors from home? The same McKinsey study that I referenced found that more than half of physicians are not willing to provide telehealth services if the reimbursement is at a discounted rate than what they would have gotten if the patient came into their office. So this is the problem with fee for service. I saw a patient, I expect to get paid X, whether it's on television or not. We're going to have to see whether providers or whether payers will do that.
Do you see any silver lining in the pandemic?
Well, I think I hate to say that there's any, but ironically, before the pandemic, we had a very low investment in what is called public health. And what we were doing in this country as an effort to try to control costs is eliminating what was called excess capacity, any kind of healthcare resources that we really didn't have to use. And that's why we didn't have PPE, we didn't have extra drugs, we didn't have all the resources that hospitals and doctors were found to be short of, because that had all been eliminated. However, by virtue of the pandemic, there's now federal legislation that has earmarked about $300 billion for public health investment in infrastructure, in workforce, and in preparedness. My concern is, will we repeat what happened after the Spanish flu? After 1918, there was an awful lot of money put into public health by Americans. And then as we moved away from that experience, we began reducing and ended up where we were, 2 years ago, totally under-resourced for this kind of a problem. So short term, more money will be poured into public health. Long term, it'll be tough to, defend that investment.
President Biden has a healthcare agenda. What is it, and what do you think of it?
Well, it's very ambitious. I really have to say, if you're a healthcare person, it's very impressive. The most impressive accomplishment, though, has been his focus on the pandemic and his efforts to get the country vaccinated. Didn't quite make the goal that he set out, but the goal was really incredibly ambitious, and we've turned around dramatically from the, you'll forgive me, failures initially to do testing and contact tracking. The federal government has also rejoined the World Health Organization, which I think most healthcare policy people think is a very good idea. He's got to restore the CDC's credibility, and we've got to restore this emphasis that we used to have as a country on data and evidence to guide health policy. The other thing that's been done in terms of insurance coverage is the administration established a special enrollment period for the Affordable Care Act health insurance exchanges to help more people to get covered. And now the administration is trying to end this Medicaid work requirement. Just in passing about Medicaid, the majority of adult Medicaid enrollees are either working or they're too ill to work because they're disabled. Anyhow, I think that he's got an ambitious agenda, and I hope much of it passes.
What are some of the innovations that we've seen in healthcare?
Well, we've had almost continual scientific innovation, but again, I'm not a scientist, so I will talk about the part of the world that I'm familiar with. If you look at the private sector, where there has been innovation, the sector is motivated by profitability. That's how the market works. And that frequently leads to innovation. However, those innovations can either reduce or sometimes increase total healthcare costs. In the private sector, for instance, insurers have developed very innovative network-based products that I mentioned earlier that encourage consumers to use cost-effective providers. They've also invested in disease management programs to make sure that patients with chronic conditions are engaged and monitored and both take care of themselves and are taken care of appropriately. In the public sector, there is an organization at the Centers for Medicare and Medicaid Services called the Innovation Center, CMMI, which was established as part of the Affordable Care Act. And it develops tests and new payment models to help improve Medicare and Medicaid and to reduce costs. And this includes things like accountable care organizations, bundled payments, and what are called medical homes. Unfortunately, the results of these experiments have been mixed. Some ACOs and some bundled payment models have succeeded in raising quality and lowering costs. Some haven't. Going forward, the challenge, and again, this is a classic health policy issue, the Congress created this entity to push innovation, but the law does not allow that entity to require the innovations to be adopted because, at the time, people felt that was going beyond government's role. So yes, I think there are innovations both in the private and the public sector, but it seems to me we've got to change the law to allow, if CMMI comes up with an innovation that actually does control costs and improves quality, they ought to be able to mandate that.
Well, Leonard, at my age, I think occasionally about the process of passing. You were on a committee that produced a report, Dying in America, which sought to improve care at the end of life. Can you talk a little bit about this?
Well, again, this is one of these situations where it's we're talking about in the context of medical science, but end of life, isn't just about medicine. Too many people in this country die in circumstances that don't reflect their personal preferences or their personal values. I mean, physicians are trained to do everything they can to keep a patient alive and to try to, it's called curative medicine, to try to cure the problem. The difficulty is, at the end of life, it's rare that the healthcare difficulties actually get cured. And the question becomes, what does the patient want? Does he or she want the doctors to keep on trying, or would they rather be left alone? And if they want to be left alone, would they like what is called palliative care, which is care aimed at reducing pain and suffering? To get at that problem, you got to have people think about end of life. And that's not something that Americans like to think about. On this committee that was put together by the National Academy of Medicine that you mentioned, one of the conclusions we suggested is that American families begin to talk about end-of-life issues when their children get their automobile driver's licenses. And that may sound crazy, but end of life doesn't just occur to old people. And particularly among young people, it's trauma that leads to early death. And the question is, do you want everything done to keep you alive? Do you want pain and suffering minimized? What are your personal values? Now, different people have different values, but it is important that we have the discussion. It's called advanced care planning and involves making decisions ahead of time about what kind of care you'd like at the end of your life, and then letting both your family and your healthcare providers know your preferences. These preferences should be put into what's called an advance directive or a living will, and they have legal power. Now, primary care physicians are uniquely positioned to promote and encourage advanced care planning conversations, and they should be trained to do so. Also, legal experts that help you with your wills and estate planning are also in a great position to sensitize people to these issues. But again, fee-for-service reimbursement is a big part of the problem. You're in the hospital, there are 3 or 4 or 5 or 6 things a doctor can do. They may or may not work, but he or she was trained to do them and they get paid to do them. So you've got to have somebody standing there saying, no, my father, my aunt, my whatever does not want an extraordinary procedure, okay? If that's what the patient doesn't want. Anyhow, I think the situation is getting better as more people learn about advanced care planning and as more physicians become aware that death is not a medical event, it's a personal one.
Leonard, I think those are great suggestions. As a matter of fact, I have taken them. I have an advanced care directive, and my doctor has it, and my hospital, UCLA, also has it. So hopefully that gives them some guidance if they need that guidance. Jessica, I think it's time that we go to questions from our fellow members out there that have been patient and listening to the program. So far, I know we've got a number of them out there, so take it away and let's have the questions asked.
Yeah, you two have covered a lot, but we've got a couple in here that will hopefully guide this conversation a little bit too. For one of the first questions, since COVID is evolving each day with changes in protocols, how do you keep up with all the new research and CDC decisions?
That is a good question. I just want to go back and make sure everyone recalls, I am not a physician. So fortunately, I don't have to keep up with this stuff in order to provide treatment. But it is a serious issue. There is a branch of medicine where physicians are highly trained around these kinds of problems. But frankly, most primary care doctors and most specialists don't deal with pandemics. So they have to look to the advice and the publications from the CDC and from their own specialty societies. So what you find, for instance, if you're a pediatrician, the American Academy of Pediatrics is putting out advice and counsel. The difficulty with COVID was it came so quickly, and the science base was not there in the beginning, that we got some very confusing messages. I think, and I want to be careful how I say this, but I think most doctors are back, understanding this the way they've understood other healthcare problems. But you have an awful lot of the population, okay, private citizens, very confused and very concerned. And I think part of the skeptics, part of the people who aren't vaccinated, have heard things on social media or saw that the CDC changed its position several times and therefore don't have the faith in what is now, I would say, mainstream thinking about COVID. So we've got to not only get the science right, we have to have better messaging, and we have to hope that all the doctors, all the practicing physicians are referring to the appropriate science that affects their specialties.
In your estimation, will a one-payer healthcare system result in decreased healthcare quality?
Well, not necessarily. I use the term single payer in my slide as kind of a humorous way, because there are systems that are literally single payer. In Great Britain, National Health Service is single payer, and it's not clear that that organizational structure results in poor quality. In fact, the UK has got higher quality care than we do. The issue is, how is it going to be administered? Who has authority and what kind of authority do they have? And the big issue about the United States is, we're proud of being a democracy, and we don't want the government to intrude in what we consider to be, personal decisions. Allegedly, Jefferson said, I think it has been disproven, but allegedly he said that that government governs best, that governs least. So Americans don't like government telling them what to do. And the fear I would have if we had a true single payer system is that it wouldn't have the authority to maintain quality, or it's possible that it wouldn't have the authority to maintain quality. And so we have to be very careful of what we do. What we got works for people who've got money and have got access to quality care, but it doesn't work for the country as a whole.
Don't these COVID and political times bring up the importance of behavioral health, family/community values and priorities that in reality make us a stronger, healthier, and happier society, short and long term?
Absolutely. The point of the comparison to other countries is very important. It's the social determinants of health, and they come from things that are not part of what we define as the healthcare system. We have a sickness and injury system. If you get sick, you have trauma, and if you can afford it or have insurance, you go to a doctor or a hospital and they will do good things for you. The real question, though, is how do we keep people healthy all their lives? And that starts long before anybody sees a doctor. That's about do you eat nutritious meals? Do you exercise? Do you keep your weight below the obesity levels? And if you do all those things and you do them early in life, you're going to live longer and better than other people. Other people who don't. Again, odd thing about Americans, we're big believers in science, we're big believers in technology. There's sort of this unspoken assumption that if I get sick, the healthcare system will cure me. Well, no. The goal is don't get sick in the first place, okay? We need, I believe, and now I'm going pretty far afield, we need much better, primary education around healthcare. I don't want to take up too much of your time, but this is my classic example. I eat an extremely healthy meal, diet throughout my life. And I can say that and look down my nose at you. However, I don't eat it because it's healthy. I eat it because when I was growing up, my mother used to look around the table and she would say, I remember this like yesterday, you need a little green on your plate. And sometimes you need a little red. And she's a mother, but this woman's crazy, what does it matter what color, 30 years later, I'm running the Department of Mental Health in the state of Illinois, and there we had inpatient facilities for people who are mentally ill, and 24,000 inpatients. And I'm meeting with the dietitian and asking, how do we know that all of our patients are getting adequate nutrition? And the dietitian says, well, we plan all the meals, we get all this nutritious food. I said, yeah, but some of many of these people are seriously ill. How do we know they're eating? They're actually consuming a nutritious meal. And the response was, well, we have nurses' aides who walk around the tables, and if there are at least 3 different colors on the plate, it's a nutritious meal. Now, I will bet when my mother was in grammar school in the city of Chicago, there was some kind of a course, and unfortunately back then, probably only girls went through that home economics course. And somebody told her, if you're going to be a good mom, your kids have to have 3 colors on the plate. That's what we need to do in terms of educating people, in my humble opinion.
No, there was a whole method out there. I think it's called eating in color that they try to teach moms how to help your kids eat in color. So you're right on.
But it was never explained to me this is healthy. It was just, what you do. And, I'm not going to fight with my mom over that. So I did it.
Well, I'm glad that you're a good eater. The next question kind of is a follow-up to that. Are doctors well educated on how to help people through improved food and exercise versus how to prescribe medications for ailments? My experience has been that those in healthcare are not always healthy.
Well, being a physician is a very difficult job. And particularly the specialists know much more about certain situations than we as lay people do. And they know how they can intervene and the changes they can make, if they're surgeons or what have you. They also know that telling people, gee, you ought to lose weight and stop smoking usually doesn't work. So there's a tendency among physicians, to not always say the obvious because they feel it's not going to have the impact. Increasingly, primary care physicians and family physicians are being trained to understand that is really important stuff. And if you've got a patient, who is obese, you really have to talk to them, and you really have to see that they make an effort to change their diets. So I think there's some good news, but whoever asked the question probably had an experience, with the doctors who they weren't interested in trying again. If you're convinced you can smoke and not get sick, the conversation's over.
Please explain how keeping workers as part-time without benefits impacts the public health care, especially since the market-based system does not work for people who are let go and jobs are lost due to technology.
Well, I mean, that's the second big problem in our healthcare system, and that is that it's so expensive. You have to have insurance to get access, and most people who have insurance have it through their employer. And until recently, most employers covered full-time employees, not part-time, and particularly not what I call now gig workers and that sort of thing. However, the Affordable Care Act made health insurance much more affordable for people who have to buy directly and created subsidies. And in the last bit of legislation, those subsidies were even increased. So it is for people with very limited resources, there is those kind of policies which are pretty good. The Affordable Care Act policies are available, and for people that are very poor, there's Medicaid. The problem again is education. It's not clear that everyone who's eligible knows they're eligible, and it's not clear that even if you have that coverage, people take advantage of it. I mean, if you can't get to the doctor's office, having Medicaid doesn't matter. You're not going to go. So we need not just health insurance. We need these other social services that contribute to what are called the social determinants of health.
Do you foresee government funding or insurance funding for naturopaths and holistic/functional medicine providers who focus on root cause of disease and positive outcomes through behavior, nutrition, exercise, sleep, and stress management changes?
I think there's a growing awareness that other types of interventions that are not classic medical interventions can be very effective. The issue of who's eligible to be reimbursed and how they're reimbursed is, I hate to tell you, it's just pure politics. And I can't say I have any idea what will happen other than some of those procedures and some of those worldviews, do have impact. And one would hope that the ones that are effective will be covered. But the way clinicians and the providers of those services are organized, it all goes through legislatures and Congress. It's very political.
This will be our final question. Should maintenance for seniors be greatly reduced in price in order to begin to reduce the overall cost of healthcare because of the growing population of people entering this demographic?
I didn't get your first word. Should what for seniors be reduced?
Sorry. Should maintenance for seniors be greatly reduced in price in order to begin to reduce the overall cost of healthcare because of the growing population of people entering this demographic?
I'm not sure I know what maintenance means. Do you? I mean, in this context.
I'm not sure as well.
We've got to reduce the cost of care that occurs as people age. We've got to find ways to do that. And I think what will turn out to be the most powerful way to do that is this remote monitoring that I mentioned earlier, because what tends to happen is that people of advanced age, stay at home until they get sick enough to go to the hospital, and then they go to the hospital and it's very costly. If you can monitor people at home and make sure that they're taking their medications and doing the other things, watching their weight, eating nutritious food, which you can do remotely. And if you do that really well, it will reduce the amount of hospital-based and other kinds of expensive services that many of those people are now consuming. And so I think there is hope for reducing what I'm interpreting as total maintenance costs. But you have to build something to replace what we have now. And I personally think it's telemedicine combined with remote monitoring, and more people will be able to stay at home. There's a secondary issue, and I don't want to be overwhelmingly boring, but that is when people are at home, the caregiver is typically a family member. And we've got to do something to help those family members. They've both got to be trained, but they got to be supported. And one of the big issues, which we won't get into, but is people with dementia. The caregiver, the family caregivers for people who have dementia, Alzheimer's particularly, that's a tough job. And there's most of those cases, the individual can stay at home until the illness reaches its final stages. But in order to stay at home, we got to help the caregiver as well as the patient. And right now, we don't do that well.
Very true. Well, to give a shout out to my mom, she helped my grandmother for the last 8 years of her life, going over there weekly, doing physical activities with her, prepping all of her meals. And it was like a full-time job that she did it. And we're so grateful because she gave my grandmother this quality years at the end of her life, that it is a big commitment, and really grateful for those family members that step up the way that they do to help people.
Oh, that's terrific. It's just very stressful. Your mom it was an easy life, let me tell you.
Yes. Yeah, she's wonderful. So anyway, on that note, Bob, I'm going to turn this back over to you, and a huge thank you to our audience for all of your great questions. And Leonard, thank you again for this great conversation.
Thank you, Jessica. And Leonard, thank you very, very much. It was a wonderful program today. I've enjoyed our friendship for so many years, and we appreciate that. I want to turn this over to Kim Maclay now, who will hopefully say a little bit about what's up and coming this next week or two for all of our members to participate. Thanks again, Kim.
Bob, thank you so much for moderating yet another superb program. And Leonard, this was so informative, so important for us to hear. I loved your data and statistics. We'd love to have you come back at some point in the future and continue to advise us. We appreciate your expertise so much. Thank you.
Thank you.
As Bob said, for our viewers, we have some terrific upcoming programs, and we're starting to bring our in-person programs. So may I quickly update you on what's ahead. Tomorrow, the Korean Peninsula Today, Making Progress on Peace and Denuclearization of North Korea. We have some special member screenings. These are great films available to our members. The Last Leonardo, August 3rd through 5th, and a Congresswoman, Barbara Lee, Speaking Truth to Power, August 13th through the 15th. Every Tuesday, of course, we have Politics in the Time of Coronavirus with politics professor Dan Schnurr. And on August 16th, Quarantine Fatigue, Travel in a Post-Pandemic World. If you're not a member, please consider joining today. You can do so on our website at lawacth.org. Not only do you have wonderful benefits and services and access to great programs, but it also helps keep our organization going and enabling us to provide you with terrific programs like today's. Everybody, please stay safe, stay informed, and we hope to see you tomorrow. Take care.